So today I'll be discussing about the four important concepts in statistics. One is about sensitivity, specificity, the positive predictive value and the negative predictive value. The second one would be the number needed to treat and number needed to harm. This number needed to treat has been recently asked in your DRNB exams in December 2022 as a 5-mark question. And next topic would be bias, what is definition and what is the classification of different types of bias with the examples. And the last topic would be blinding, the definition and classification. So first I would be discussing about the sensitivity, specificity, PPV and NPV. So what are all these four components? So these are nothing but an important measures of a test's accuracy and a predictive power. So we'll go to the definitions. So what is sensitivity? It denotes the proportion of subjects who are correctly given a positive assignment out of all the subjects who are actually positive for the outcome. Very difficult to remember. It means how well a test can classify subjects who truly have the outcome of interest. Okay, that means sensitivity. Now, what is specificity? So, it denotes the proportion of subjects correctly given a negative assignment out of all the subjects who are actually negative for the outcome, which means how well a test can classify subjects who truly do not have the outcome of interest. Okay, that is specificity. Now, what is positive predictive value? It reflects the proportion of subjects with a positive test who truly have the outcome of interest. And what is negative predictive value? It reflects the proportion of subjects with a negative test result who truly do not have the outcome of interest. So definitions very difficult to remember, but when we go to examples, I think you will be understanding it more precisely. Now coming to sensitivity and specificity, they indicate the concordance of a test with respect to a chosen referent. Whereas positive predictive value and negative predictive value, they indicate the likelihood of that test which identified whether people do or do not have a target condition based on their test results. So usually the sensitivity and specificity, they are inversely related, wherein one increases as the other decreases, but they are generally considered stable for a given test. Whereas the positive and negative predictive value, they inherently vary with pretest probability, that is any changes in population or disease prevalence. Now, how do you calculate that sensitivity? Okay, so basically these sensitivity and specificity are commonly used to assess the performance of an alternative test against the gold standard. So you have two tests, one is the gold standard, one is the one which you are comparing against the gold standard. So at such a point of time, you're going to use these two, sensitivity and specificity. So this is given by two of the formulas. So sensitivity is nothing but correctly identified as affected divided by total number of patients affected. That is nothing but true positives divided by true positives plus false negatives. Okay, specificity is correctly identified as unaffected divided by total unaffected, which means true negatives divided by true negatives plus false positives. I think you will understand it more better in the next slide. So what is positive predictive value and negative predictive value? So since sensitivity and specificity, they are highly relevant statistical parameters for assessing the performance of a diagnostic test. However, in the real world practice, rather than knowing the proportion of diseased patients who will test positive, it is often more meaningful to predict whether a particular person will truly have the disease based on a positive or a negative test result. Okay. So to this end, positive predictive value and negative predictive value, they reflect the proportion of positive and negative results that are true positives and true negatives respectively. So leave off all this. Now, in other words, what do you mean by positive predictive value? So if you have a positive test, okay, what is the probability of I actually having the disease? So if your COVID test is positive, RT-PCR, what is the probability of me having the disease? Is positive predictive value. Now, what is negative predictive value? If I have a test negative, what is the probability that I actually do not have the disease? That is the negative predictive value. Okay. So this is given by positive predictive value and negative predictive value is given by true positive. What is positive predictive value? True positive divided by true positive plus false positives. Whereas negative predictive value is given by true negatives divided by true negatives plus false negatives. Okay. So basically all these four are actually depicted in a standard 2 into 2 contingency table. Okay. So now go through this table. So actual status means whether the patient has a disease or do not have a disease is plotted here. And assignment status, which is nothing but the test. What test you are doing for that patient. Okay. Example, you took the COVID test. So test is positive, test is negative. Okay. So those patients who have a COVID and who also test positive for a COVID RT-PCR, those people are known as true positive. Okay. Those patients who do not have the COVID but they test positive for COVID, they are known as false positive. Okay. People or patients who are disease positive but the results are negative. Your COVID RT-PCR is negative. Okay, those people are known as false negative people. So those patients who have a disease negative and also the test is negative, they are known as true negatives. Okay. So this is the table. So you will have all these four here. Sensitivity, specificity, positive predictive value, negative predictive value. So very difficult to remember this, right? I think sir has already shown this slide, Dr. Tapas. So just remember, sensitivity if you need to calculate, see this red arrow. Okay. So sensitivity is calculated by true positives divided by true positive plus false negative. Okay. Now coming to specificity, the blue line. So true negatives divided by true negatives plus false positive. That is specificity. Coming to the positive predictive value. So true positive divided by true positive plus false positive. Okay. And negative predictive value is true negatives divided by true negatives plus false negatives. Okay. I hope you understood this. Okay. Now, this is an article which was published in American Journal of Urology in 2018 by Amin Sharifi. So basically, they tested uh, the prostate specific antigen density. Okay, we all know prostate specific antigen is one of the methodology of detecting the prostate cancer if the values depending upon the values. So what is this prostate specific antigen density? It is nothing but the prostate specific antigen divided by the volume of the prostate, which is usually calculated by the transrectal ultrasonography. So, in this article, they have tested this prostate specific antigen density, whether it is able to predict the positivity of prostate cancer. Okay. So, so this is the table which is given here. So can you people please calculate the sensitivity, specificity, positive predictive value and negative predictive value and just put it in the chat box. I'll give you some time. Just remember this. I will give you the values here. Please go through the values. Darshan, did anyone answer it in the chat box?
None, unfortunately, none yet. Guys, okay, there's one. Hi, Dr. Prabhakaran, 0.91 answer. Very good. Okay. There are a few answers coming in.
Yeah.
I think so we can reveal the answer.
Okay. Okay.
Good,
So
good.
So basically, how do you calculate sensitivity now? So totally, 489 subjects were identified as true positives, right? So these are the true positives. Okay. And 10 subjects were false negatives. I'm so sorry. 10 subjects were false negative. So it will be 489 divided by 489 plus 10. So the answer would be around 98%. So the sensitivity of this prostate specific antigen density to diagnose the prostatic cancer is around 98%. Okay. So what is this 98% sensitivity indicates? It means that 489 out of 499 subjects with clinically significant prostate cancer were correctly identified as positive using this PSA density. The cutoff value in this study was less than or equal to 0.08. Now coming to the specificity. So how do you calculate specificity? It is true negatives divided by true negatives plus false positives. Okay. So the true negatives were 263. So 263 divided by 263 plus 1400. Okay. So the answer would be around 16%. Okay. So what does 16% specificity means here? It means that 263 out of 1663 patients without clinically significant prostate cancer, they were correctly identified as negative using this test. Okay. So this is about sensitivity and specificity. Now coming to the positive predictive value and negative predictive value. So positive predictive value is given by, I think formula we already know. So if you calculate it, so the positive predictive value is coming to up to 26% and negative predictive value is 96%. Okay. So what does that mean? 26% of subjects with a PSA density of greater than or equal to 0.08 truly had clinically significant prostate cancer, whereas 96% of patients with the PSA density of less than 0.08 truly did not have a clinically significant prostate cancer. Okay. So this is about the positive predictive value and negative predictive value. So I hope you people understood the concept of sensitivity, specificity, positive predictive value, negative predictive value, and how to calculate it. Okay. Now we will go to the second topic, the number needed to treat and number needed to harm. So this was recently asked in your exam. So what is number needed to treat? So this is one of the derived statistic parameter which tells us how many patients must receive a particular treatment for one additional patient to experience a favorable outcome. Okay, this is about number needed to treat. Okay, what is number needed to harm? It tells us how many patients must receive a particular treatment for one additional patient to experience a particular adverse outcome. That is number needed to harm. So usually lower number needed to treat and higher NNH values are associated with a more favorable treatment profile. Okay. Both these terms are commonly used in RCTs and observational studies to provide a simple measure of what is the effect of the treatment. Now, for example, you take the PROSEVA trial. Okay, so in PROSEVA trial, they compared the prone positioning in severe ARDS. So in patients with severe ARDS, prone positioning decreased 28-day all-cause mortality compared to supine positioning. that is 16 versus 32.8%, with a number needed to treat of 6. What does that mean? So, 6 patients with severe ARDS would need to be treated with prone positioning in order for one additional patient not to die within a 28-day period. Okay. Now, how to calculate this number needed to treat? So, it is calculated by 1 by absolute risk reduction. I think absolute risk reduction has already been explained to you in the previous class. So how do you calculate this absolute risk reduction? It is calculated by CER minus EER. What is CER? Control event rate. Means in the control group. Okay, what is the event that you are calculating minus the experimental event rate. Okay, this is how you calculate the absolute risk reduction. Okay, and entities are always rounded up to the nearest whole number. It will not be in any points. It should be rounded to the nearest whole number. Now coming to the example. So this was a very old article in 2002. So we are going to see the dexamethasone in adults with bacterial meningitis. So here around 301 patients were enrolled. 157 patients were receiving dexamethasone and 144 patients were receiving placebo. Now, this is the outcome which they have seen. So the unfavorable outcome was measured in the form of Glasgow outcome scale. Okay. Now, taking this data, please calculate what is the number needed to treat for this patient group. Okay, so you calculate the number needed to treat for unfavorable outcome and you calculate it for death. So would anyone like to do this? I'll give you some time. So 1 divided by absolute risk reduction. Okay, that is control event rate minus experimental event rate. So you need to calculate the ARR for each of these, for unfavorable outcome and also for the death. Anyone answered in the group chat box? Okay, so I'll just proceed. If you have answered it, please chuck it here, whether your answer is correct or wrong. So basically now we have to think of 4 things. So what was the condition? It is meningitis. What is the intervention? Dexamethasone versus placebo we have kept. So what was the events being prevented? Unfavorable outcome. And the duration was up to 8 weeks in this study. No, now as I told, you have to calculate the control event rate for unfavorable outcome and control event rate for death. So control is the placebo group. Okay. So for all patients, you are going to calculate the CER. Okay. So what is CER? As I told, CER would be 36. Okay. 36 by 114, the number of total population and how many of them had a unfavorable outcome in the control group. Okay, so it is 36 divided by 144. Similarly, the ARR for death is 21 divided by 144. Okay, so that would be 0.25 here, 0.15 here. Now, similarly, we need to calculate the we need to calculate the experimental event rate. Okay, so how do you calculate the experimental event rate? You have to take the experimental group. What is the experimental group here? You are giving dexamethasone, right? So unfavorable outcome would be 23 by 157, and the ARR for death would be, ER for death would be 11 by 157. Okay. So that would be 0.15 and 0.07. So as I told, ARR would be CER minus EER. Now first we will calculate the ARR for unfavorable outcome. So what is the CER for unfavorable outcome? It is 0.25 minus the EER for unfavorable outcome, which would be 0.15. So it is about 10%. The absolute risk reduction is 10% for unfavorable outcome. Now, similarly, you need to calculate the absolute risk reduction for death, which is 0.15 minus 0.07, which is nothing but 8%. Now, after this, you need to calculate the NNT separately for unfavorable outcome and death. So, NNT I told 1 divided by ARR. So, 1 divided by, so this is 10% or 0.10. So, 1 divided by 0.10 will be 10. So, you would need to treat 10 meningitis patients with dexamethasone in order to prevent one patient getting an unfavorable outcome after 8 weeks. Okay. Similarly, in order to prevent death, okay, you need to treat around 13 meningitis patients with dexamethasone to prevent one death after 8 weeks. Have you people understood this? This is a very important thing that you need to understand. So if you have not understood, we'll go back again. Okay. Now, similarly, please calculate for the adverse events. So it is nothing but the number needed to harm. So what is number needed to harm? It is 1 divided by absolute risk increase, ARI. There it is absolute risk reduction. Here it is absolute risk increase, because we are going to see the number of adverse effects which are happening in this study. Okay. So similarly, this is the data which I have given here. So can you please calculate the NNH for hyperglycemia and fungal infections? So if you want, what is ARI? ARI is same, CER minus EER. Okay, for that particular adverse effect. So calculate it for hyperglycemia and the fungal infections. Okay, so for hyperglycemia, so what would be your CER? If you see hyperglycemia, this is the control. So 144 patients are there, in which around 37 patients had showed hyperglycemia. So 37 divided by 144 will be your CER. Whereas your EER would be 50 divided by 157. Okay. So CER for hyperglycemia is 37 by 144. So it would be around 26%, whereas EER for hyperglycemia would be 50 divided by 157, which is nothing but 32%. So now your number needed to harm would be CER minus EER. Okay. Similarly, for fungal infections, you have to calculate like the same. Okay. So now for hyperglycemia, 1 divided by absolute risk increase. So 1 divided by, what was the answer which you got if you minus these both, 0.26 minus 0.32. So you are going to get 0.06. So it will be around 17. So you would need to treat 17 patients with bacterial meningitis, okay, with dexamethasone to cause 1 case of hyperglycemia over 8 weeks. Okay. Similarly, for the fungal infections, you need to treat 50 patients with 50 patients with meningitis with dexamethasone to cause 1 case of fungal infection over 8 weeks. Okay, so this is about the number needed to harm. Calculation wise, it is the same. Only for number needed to harm, we need to see the adverse events, and for number needed to treat, you have to see the outcomes, the primary outcomes. Okay, I hope you have understood this, how to calculate it. So now what is the importance of the value of this NNT? As I previously mentioned, the smaller the NNT, the greater the unique distribution of the drug towards the outcome. For example, the NNT for a drug is 4, which means that 4 patients need to be treated with that drug for 1 additional patient to respond. In contrast, if the NNT is high, example it is 18, it means that as many as 18 patients need to receive the drug for 1 additional patient to respond. Okay, so this NNT cannot lie between 0 and 1. The lowest value for NNT, that is 1, is obtained in the impossibly ideal situation in which the response rate to both the drug and the placebo are 100% for the drug and 0% for the placebo respectively. Whereas the highest possible value for NNT is infinity, in which the response rate both in the treatment as well as the control group is the same. In such cases, the number needed to treat will be infinity. So both these are not the ideal conditions which we see in the regular practice. So what are the limitations of this number needed to treat? So first is about the interpretation. So the clinical meaning of NNT is open to interpretation, which means some doctors may consider a NNT of 100 over 5 years to be healthy, to be a health benefit, whereas others may consider it to be only a moderate or a slight benefit. Okay. So it depends on who interprets this result. So it depends on the interpreter. Okay. Second, side effects. Okay, the NNTs do not account for side effects or adverse reactions to medical interventions. Hence, we have something known as NNH. Okay, time interval. These NNTs depend on the time interval over which the medical event of interest is assessed. For example, the NNTs may be different if the time interval is 1 versus 5 years. Okay, which means that if you extend the within 1 year, some patients might have a positive effect which might wean off as the time proceeds. So when you calculate the NNT for 1 year, the value would be different for the same patient, whereas if you calculate it in the 5 years later, the value would be different. Okay. Coming to the meta-analysis, these NNTs cannot be used for meta-analysis because the baseline risk often varies between the different trials, because meta-analysis involves a lot of trials in it. Okay, coming to the risk-benefit ratio. NNTs cannot be used to calculate the risk-benefit ratio for an individual person. And this NNTs can be distorted when placebo effects approach the treatment effects, which I told infinity. When NNT is infinity, which is not ideal. And it can be difficult to estimate the NNTs if the confidence intervals are provided for a test as the results. Okay, so in that case, if confidence intervals are provided, you can't calculate the number needed to treat. Okay, so this is about the number needed to treat and number needed to harm. So next comes bias. So what is bias? It is nothing but a systematic difference between the true parameters of a population and the statistics used to estimate those parameters. Okay, in other words, it refers to a flaw in the experiment design or the data collection process which generates results that don't accurately represent the population. So this bias can occur at any phase of the research, at the starting to the ending of the study. Anywhere this bias can occur. Some degree of bias is nearly always present in a published study. We need to just consider how this bias might have influenced a study's conclusions. Okay, so minimal bias is acceptable, but that bias should not be so significant that it will affect your study conclusions. This bias is independent of both the sample size and the statistical significance. Now, as I told, the bias can occur anywhere in the trial. So it could be in the pre-trial, it could be during the trial, or it can occur after the trial while you are analyzing the data. So in the pre-trial, what are the different biases which you can face? One is the study design only is flawed. Second, what is selection bias and channeling bias? Okay, now coming to the bias during trials. So you have the interviewer bias, chronology bias, recall bias, transfer bias, performance bias. And while analyzing or publication, you have two important bias. One is the citation bias and the other one is the confounding bias. So we will go with the individual one. Only important ones I have been discussing. So the first one would be the selection bias, or also known as Bergsonian bias. So this type of error occurs when a systematic error in the enrollment of the individuals in a study, either it could be cases or controls in a case control study, or exposed or unexposed individuals in a prospective cohort study, which determines a biased association between exposure and outcome. Okay. So you have three types of, again, bias in this selection bias. One is the incidence prevalence bias, one is a loss to follow-up bias, and the publication bias. So coming to the incidence prevalence bias, also known as Neyman bias or survival bias. These are all short note questions which are expected. So the selection bias is one of the important bias that you people need to know. So what is incidence prevalence bias? I think already you know the definition of incidence and prevalence. I'm not going to explain about those things. So what does this bias mean? This occurs, okay, when we try to estimate the risk of a disease on the basis of data collected at a given time point in a series of survivors, rather than data which is gathered during a certain time period in a group of incident cases, or when the sample of cases offers a distorted frequency of exposure. Okay, this type of bias is particularly relevant in case of cross-sectional studies. Now, example. Basically, when I tell the example, I think you will be understanding this. So you have a cohorts of around 20 individuals with a follow-up period from 0 to T2. Okay. So during this follow-up, just go, these pink are the new cases of moderate disease, green are the new cases of severe disease, and the white balls are about the death, the number of deaths which are occurring during this period of 0 to T2. Okay. So during this follow-up period, 4 individuals, if you see, 4 individuals have developed moderate disease, whereas 4 individuals have developed a severe disease. Okay. So when you calculate the risk ratio between the risk of severe disease versus the moderate disease, it would be 1. 4 by 4, it would be 1. So your risk ratio during this time period is 1. However, people with severe disease, they have a higher risk to die. So in this time period of 0 to T1, already 2 patients have already died. So now if you want to perform a cross-sectional survey between this T1 and T2 at a fixed time point, like T1. Okay, if you see here, the number of moderate cases are 2 and the number of severe cases is only 1. Okay, so 1 divided by 0.5 would be, so we get a prevalence ratio of severe versus moderate disease as 0.5, right? So this will not reflect the true risk ratio, which is actually 1. But when you are calculating at one particular time at T1, then it is 0.5. Okay, so this is the bias which is present in the incidence prevalence bias. Okay, so you need to measure over a period of time. Okay, if you measure at a single particular time, then you will not be able to get the proper risk ratio. Okay, so this is about the incidence prevalence bias. Now next is the loss to follow-up bias. So this bias occurs basically in prospective cohort studies when individuals, they lost to follow-up do not have the same probability of having the clinical outcome of interest in comparison with individuals who remain under observation. Example for this is, okay, you're going to determine the incidence of renal insufficiency in hypertensive and normotensive individuals. Okay, so two groups you have made and you want to know which patients would develop renal insufficiency. So we know that it takes a lot of time for the hypertensives to develop renal insufficiency, mostly some months to years, right? So as a consequence, what happens, these normotensives who did not develop any disease after several years of observation, okay, they may be less stimulated to continue the study, okay, compared to those who have hypertension. So what they do, they just leave the study group and just go. So this is known as lost to follow-up bias. Okay, because it might take some time for these non-hypertensive patients to get renal insufficiency. When they just go out of the study, then all of your results will be manipulated, or it's just lost, and you will get a bias in that. So next would be the publication bias. So what is publication bias? It is generated in the selection process of information that is eventually published. So it depends on several factors, like what is the study size, what is the design, what is the quality, who is funding, and the prestige also. So example for this would be, so Kaczynski et al. Has collated 13 studies on lipid lowering and renal outcomes in patients with CKD. So they saw that lipid lowering agents would reduce the bad outcomes in chronic kidney disease. So it is a systematic review. In this 13 studies, only 2 studies out of 11 have reported a negative effect of treatment on albuminuria or proteinuria. Okay, a possible explanation for this phenomenon is that journal editors might have been biased in accepting studies reporting a negative effect of treatment, or alternately, authors of negative studies might have not submitted them because of low probability for these studies to be accepted. Okay, so basically what does this mean? If any study is negative, means these lipid lowering agents actually caused any rise in bad outcomes in CKD patients, then such studies usually will not be published. Okay, if they are not published, then we will not be knowing the exact outcome of the remaining studies when you compare both the studies, right? So that is about the publication bias. Now coming to the channeling bias. So it occurs when patients' prognostic factors or degree of illness, it dictates the study cohort into which the patients are placed. Okay, so this bias is more likely in non-randomized trials when patient assignment to groups is performed by a medical professional. For example, what is channeling biases? So we are going to consider operative versus non-operative management of hand fractures. Okay, so when you randomize these patients, okay, usually how do you randomize? If you know that if it is a medical personnel, then he would randomize young patients into the operative study group because they will be more benefited. Okay, whereas elderly would be channeled into a non-operative cohort study. Okay, because they will not be doing anything much in the future with that hand, right? So this is known as channeling bias. So you'll be actually assigning them, the young patients, into one group, and old elderly patient into the one group. When in the actual thing, both has to be mixed and distributed equally into the two groups. Okay, next coming to the information bias. So this occurs during data collection. So there are two types of information bias. One is misclassification bias and the other one is the lead time bias. So what is misclassification bias? So it originates when the process to detect the exposure status, okay, and or the outcome is imperfect. That is, basically the exposed or diseased individuals, they are classified as non-exposed or non-diseased, or vice versa. Example for this would be, okay, so you are using only one size BP cuff to measure the BP both in the lean as well as in the obese individuals. So when you measure like that, so there would be an abnormal readings, right? It is different. So you should use an appropriate cuff. So as an effect of the inappropriate size of the cuff, we can classify a normotensive individual as hypertensive and vice versa. So this is known as misclassification bias. Now coming to the lead time bias. What is this lead time bias? This is nothing but the added time of illness which is attributable to the fact that we apply to selected patients different criteria for the diagnosis of the disease. Okay, example for this would be any patient, suppose if the patient, HIV patient, so you have two patients. One patient is in his latent period, whereas the other patient is having a full-blown HIV. So when you diagnose this patient in the latent period, you know that the test would be negative. Similarly, in the second subject who has actually showing some symptoms, and if you detect that patient during that symptomatic phase, then you would have a positive result. So that is known as lead time bias. Basically, you're diagnosing in the latent period or in the early phases of the disease. Okay, versus diagnosis which is made in the advanced stage. That is known as lead time bias. Now coming to the next one, the interviewer bias. What does that mean? So it refers to a systematic difference between how information is solicited, recorded or interpreted. Okay, it is more likely when the disease status is known to the interviewer. Okay, example for this would be a patient with Berger's disease who is enrolled in a case control study which attempts to retrospectively identify what are the risk factors which is causing this Berger's disease. So, if the interviewer is aware that the patient has a Berger's disease, then you try to probe for the risk factors, right? So, you are asking the patient off and on, are you sure you have never smoked? Never, not even once. So, when you probe the patient like that, okay, so at some point of time, patient might have smoked some years somewhere, some years back, or he has just smoked intermittently. Okay, so interviewer bias is basically when the interviewer knows that what is the disease and he tries to get that specific risk factor to know what has caused the disease. Okay, so this can be minimized or eliminated if the interviewer is blinded to the outcome of interest or if the outcome of interest has not yet occurred, as in case of a prospective trial. Now coming to the recall bias. So it refers to the phenomenon in which the outcomes of treatment, whether it is good or bad, may color the subject's recollections of events prior to or during the treatment process. So example for this would be the perceived association between autism and the MMR vaccine. So basically MMR vaccine is given to the children during a prominent period of language and social development. So as a result, parents of children with autism are more likely to recall immunization administration during this developmental regression, and a causal relationship may be perceived. So basically MMR will not cause autism, but the parents think that when MMR is given during that period of time, the autism might have developed to some other reasons, okay, genetic reasons, but the parents attribute this to the MMR vaccine and give a false, what to tell, they will give about a false causation as the false etiology as the cause for this autism. Now coming to the citation bias. So this refers to the fact that researchers and trial sponsors may be unwilling to publish the unfavorable results, believing that such findings may negatively reflect on their personal abilities or on the efficacy of their product, especially the big pharma companies. So when the results are negative, they usually don't like to publish these results. Okay, so thus positive results are more likely to be submitted for publication than the negative results. Such bias is known as citation bias. And the last one is the confounding bias. So what is confounding bias? So what is confounder? It is nothing but a variable which influences both the dependent variable as well as the independent variable, causing a spurious association. So, this one would be independent variable which is causing the dependent variable to happen. And what is the confounding variable? It basically affects the relationship between these two variables. Okay, example for this would be, sorry. So examples for this would be So if you feel, so independent variable here is exercise, whereas the dependent variable is blood pressure. So the ability of the exercise to reduce the blood pressure is the one which we are going to study in one of the article or one of the study you feel. So one potential confounding variable here would be the starting weight of the patient, okay, which is correlated with the exercise as well as it has a direct effect on the blood pressure, right? The starting weight. So if the weight is more, so the chances of patient having the blood pressure is more, right? So while increased exercise may lead to reduced blood pressure, this is what we are going to see normally. This is the study which we are thinking to plan. But an individual starting weight also has a big impact on the relationship between these two variables. Okay, so this is the confounding variable or the confounding bias. So it occurs when an observed association is due to three factors. One is the exposure, which is nothing but the independent variable, the outcome of interest, which is nothing but the dependent variable, and the third factor is independently associated with both the outcome of interest as well as the exposure, that is nothing but the confounding factor. So the other examples are coffee drinking and heart attack, which could be confounded by smoking. The other thing is association between income and health status, which could be confounded by the access to care. So how to minimize this confounding? So we have to do pre-trial study. Design has to be done to control the confounding. So prior to the study, matching patients for demographics and the risk factors can create similar cohorts among identified confounders. This is also one of the way that you can prevent the confounding. However, the effect of unmeasured or unknown confounders may only be controlled by true randomization in a study with a large sample size. And the last one in the bias is, you should know what is Hawthorne effect. Okay, it occurs when a participant's behavior changes as a result of being observed rather than as a result of an intervention. So in other words, the group of individuals, a group or individuals, they realize they are being observed, they may change their behavior. Okay, this can be a positive or a negative behavior depending on the research context. For example, most common example, hand washing. So hand washing among the medical staff, okay, there was a study which found that when the staff knew they were being watched, compliance with hand washing was 55% greater than when they were not being watched. Okay, so this is nothing but the Hawthorne effect. Okay, it is a subtype of a performance bias. So this is just a history of how this Hawthorne effect happened. So basically, this Hawthorne effect that took place in 1920s, as old as 1920s, at the Hawthorne Works, which is nothing but a Western electric plant in Cicero. So the objective was to investigate whether manipulating working conditions such as lighting increased worker productivity. So dim light and all would not help in, would not make the workers more active, right? So they thought that any working environment like creating a bright light or sufficient light to so that they can work properly, they looked for this. And initially, the results suggested that productivity improved whenever any changes to those variables were made. So they thought that yes, they improved the lighting, so the productivity improved, including negative changes like reduced lighting. However, any change in productivity disappeared when the experiment stopped. So when they actually checked it properly, they came to a conclusion that the productivity increased because these people, they came to know that they were being supervised. Okay, so the supervisors above them were actually watching them. So the productivity increased. It is not due to the improvement in lighting or any other environmental factors. So after which this Hawthorne effect, actually they named this thing as Hawthorne effect because of this incident. So changes in behavior attributed to Hawthorne effect can seriously distort your conclusions, especially in terms of any assertions which are made about causal relationships between variables. Basically, it affects both the internal validity as well as the external validity. Okay, that you have to know. So how to prevent this Hawthorne effect? Okay, you have to explain the study. You have to explain what the study is being done to test the design, but not the participants. Otherwise, they become more alert. Okay, you need to observe people in their natural surroundings without being seen. You have to make sure that the participant responses are confidential or anonymous. And you should get familiar with the participants, because people are less likely to change their behavior if they are being watched by someone they know. Okay, if you are more close to them, then they actually don't change their behavior much. They will show you the true colors, right? So use multiple observers. So have multiple people independently recording and observed to see how these individuals perform. This is about the bias. Now coming to the blinding. So what is blinding? It is a process which is used in clinical trials as well as the epidemiological studies to keep participants, investigators, and assessors unaware of the treatments which the participants are receiving. Okay, so it is also known as masking. So this blinding could be single blinding, double blinding, or triple blinding. So what is single blinding? Just remember this diagram so that it is easy to remember. So single blinding is where the participants, they do not know to which group they have been placed in the study until after the experiment has been finished. So you are going to blind only the participants in a single blinding. So why do you need to blind? Okay, example for this would be, so example is you have developed a new flu vaccine. So you have to test the effectiveness of this new treatment. So you're going to give half of your patients the flu vaccine and the remaining half some fake vaccine, or you are going to give some placebo which has no effect. Suppose if the participants know that they are receiving a fake vaccine and they are not protected against the flu, they come to know that you are not giving any vaccine for them and they are just being given a placebo. So they might modify their behavior in ways that lower their chances of becoming sick. For example, they start washing their hands frequently, they start avoiding the crowded areas because that's where you're going to get the flu commonly. Okay, so this behavior could narrow the gap in sickness rates between the control group and the treatment group, thus making the vaccine seem less effective than it really is. That is the reason you need to blind the participant. Okay, now what is double blinding? So here you are going to blind both the participants as well as the researchers. Okay, so why do you want to blind the researchers? Okay, so in the same example you take, okay, so you have recruited several experimenters to administer your vaccine and measure the outcomes of your participants. So if suppose these experimenters knew which vaccines were real and which were fake, okay, they might accidentally reveal this information to the participants, or they could directly influence the results. How? If the experimenters expect the vaccine to result in a lower levels of flu symptoms, they might accidentally measure symptoms incorrectly, thus making the vaccine appear more effective than it really was. Okay, hence you need to even blind the researchers. And which is the best type of blinding? It is the triple blinding, where you even blind the analysts, data analysts, or the one who is doing the who is actually getting your results. So triple blinding is where you actually blind all the three group of people. Now, what is the importance of blindings? So it helps to ensure the study's internal validity, or the extent to which you can be confident that any link you find in your study is a true cause and effect relationship. And second one, since non-blinded studies can result in participants modifying their behavior or researchers finding effects that do not really exist, so it is an important tool to avoid the research bias, which I've already discussed, okay, in the scientific research. Okay, so this is about the blinding. So these are my references for all the 4 topics.